it's Olivia. Welcome back to your endocrinology chapter. In this section, we'll be covering the thyroid. So first, we'll start out with the embryology and development of the thyroid and parathyroids. Then we'll talk about some of the anatomy and function of our thyroids, how T3 and T4, our thyroid hormones, get made. Then we'll cover some causes of hyperthyroidism, as well as some causes of hypothyroidism. And finally, we'll finish up talking about some of the thyroid neoplasms. So let's get started. In this section, we'll be talking about the development or the embryology behind the thyroid and parathyroid. And why I want you guys to be aware of that is there's some key pathologies that are going to directly result from errors in the embryological development. So if you understand embryology, it'll really help you understand those pathologies that might show up on step 1. Now, before we dive into the pathology, I want to orient you to our two drawings over here. So in this first drawing, this is going to be what's going on in your fetus. This little guy is going through embryology or development. And as you can see, we are mostly concerned with this blue area right here. This blue area is going to be your endoderm. What's going on basically is your endoderm at this little point called the foramen cecum at the base of the tongue. We are going to have an outpouching or a diverticulum of the blue endoderm that is going to descend downward, and then we have this long string that we call the thyroglossal duct, and at the end of the string, that is where we have your thyroid. So your thyroid is essentially going to be dangling down from this thyroglossal duct. Think of a spider at the end of one strand of its web, or a yo-yo if that helps you, and the thyroid is dangling at the end of this thyroglossal duct that is attaching it to the endoderm at the base of the tongue, right by the foramen cecum, and it's going to be descending down in front of your hyoid until we transition over to the adult picture, and you can see we have our thyroid ending up in our anterior neck. So our thyroid started all the way up here by the base of the tongue, by the foramen cecum, then it descended downward anterior to the hyoid and ended up right in the front of the neck. So that's an overview of what's going on with your thyroid during embryology. Some key points to remember here is that the thyroid originates from endoderm between the first and second pharyngeal pouches. So these little outpouchings from the endoderm here are pharyngeal pouches. This endoderm between the first and second pharyngeal pouch is what is going to give rise to our thyroid. It comes off near the base of the tongue. We already talked about this. Near the base of the tongue, we have that foramen cecum, which is going to be the opening from the base of the tongue into the thyroglossal duct. We're going to have that outpouching or diverticulum formation around week 3 of development. And then we're going to have this caudal migration. Caudal migration meaning tip to tail or head to toe. And here we can see the caudal migration as the thyroid is descending down from the tongue towards the feet, ending up, of course, in the anterior neck. And as we're descending downwards, we are going to be descending anterior to our hyoid bone. That's going to be a key landmark. So you can see our hyoid bone over here is posterior to the tract of the thyroglossal duct. And just like in life, our hyoid bone in the adult, as well as our laryngeal cartilage and our larynx, are both going to be posterior to the location of our thyroid once we have fully developed. Once our thyroid has migrated downward, we're going to get separation of our right and left lobes. This usually occurs around week 5. And then our thyroglossal duct, I think its name kind of gives away what it does. Thyro meaning thyroid, and glossal meaning tongue. So think of your glossopharyngeal nerve, glosso meaning tongue. We have our thyroglossal duct, so it's attaching the tongue to our thyroid. And that is going to be the duct that we talked about that connects the thyroid and the tongue during the descent of our thyroid. It's that string that's holding the two together. And it's going to be incredibly important for the descent of the thyroid, right? Because our thyroid is dangling off of it. But the thyroglossal duct is not a permanent structure. So it should obliterate by week 8 to 10 after our thyroid is in the correct position. As you can see, our thyroglossal duct on the adult image is just a pathway. It doesn't actually exist anymore because it should be completely obliterated. And if it doesn't obliterate, that is when we are going to see one of our key pathologies. But just remember, in the adult, I have this dotted line here to show that the thyroglossal duct has obliterated. It's no longer there, but it is a very real structure that is incredibly important for embryological development in our fetus picture. So keep that in mind. While our thyroid is developing, we also are going to have our parathyroid developing. So the dorsal wings of the third pharyngeal pouch are going to give rise to our inferior parathyroid glands during week 5. And then our dorsal wings of our fourth pharyngeal pouch are going to give rise to our superior thyroid glands around the same time. And I think this is pretty easy to remember because the larger number 4 for the fourth pharyngeal pouch is going to be more superior than the smaller number 3 for the third pharyngeal pouch. And I just remember that we count up, so we are going to have the higher number, the fourth pharyngeal pouch, giving rise to the more superior parathyroid glands. Additionally, the ventral wing of the fourth pharyngeal pouch is going to give rise to our parafollicular C cells. And these cells are going to be really important because they're going to be the ones secreting calcitonin, which has a lot of jobs in bone homeostasis, calcium homeostasis, which we'll talk about in later videos. Finally, the fourth and the sixth pharyngeal arches are going to give rise to your thyroid cartilage. And your thyroid cartilage, I didn't draw it here on this diagram, but it's going to be a little bit lower than the hyoid bone and a little bit higher than the thyroid. So you can imagine it somewhere in this region, even though it's not shown on your diagram. So we've covered some of the embryology of the thyroid gland, but what happens when things don't go as planned? Well, our first pathology, ectopic thyroid tissue, is going to be a result of your thyroid not descending all the way down the path of the thyroglossal duct. So we're going to have halt in our descent earlier in this pathway. And that is going to lead to thyroid tissue that's located outside of the normal position in the anterior neck, right? We didn't make it to this anterior neck position. So we're going to have thyroid tissue that's in a different spot. And this is most commonly going to occur at the base of tongue. That should make sense to you because we started out at the base of our tongue. And if the problem is that we're not descending all the way, it makes sense that we wouldn't even get started with our descent. So the most common ectopic thyroid tissue is going to be found at the base of your tongue. But like I said, we can halt this descent at any point. So you might find thyroid tissue anywhere along the path of the thyroglossal duct, depending on where we halted the descent of the thyroid during this process. So again, this is a failure of embryological descent. We didn't descend all the way along our thyroglossal duct. We most commonly see our thyroid tissue at the base of tongue, but it can occur anywhere along this thyroglossal duct pathway. And then usually ectopic thyroid tissue is pretty asymptomatic. The only time you would really see symptoms here is if we have a physical obstruction of any of the structures that are around the thyroglossal duct pathway. And if you're messing with those structures, this could lead to things like cough, difficulty swallowing, or a snore, just because of the physical obstruction of some of our adjacent structures. We usually diagnose our ectopic thyroid tissue either with thyroid scintigraphy. So essentially we give someone some radiolabeled or radioactive iodine, their thyroid takes it up, and then when we put them in a scanner, we can see where all of that iodine went. And if we see a large pocket of iodine that is outside the area of the normal thyroid, then we know that we have some ectopic thyroid tissue. Additionally, you can perform an ultrasound. Sometimes you can see a mass that might be suspicious for ectopic thyroid on ultrasound. And then management is usually surgical resection or radioiodine ablation of the thyroid. So that's giving a bunch of radioactive iodine that will eventually kill the thyroid. And as you might imagine, if we do surgery to remove thyroid tissue and that was the only thyroid tissue present in the body, or if we ablate any thyroid tissue that was in your body to begin with, that can lead to hypothyroidism because we just got rid of all your thyroid tissue. And in this case, we would have to replete thyroid hormones with levothyroxine or something like that for the rest of their lives. Now, the second pathology that I want to make sure that you guys are aware of is the thyroglossal duct cyst. And remember, I told you that the thyroglossal duct should involute or obliterate. Well, in this case, we are going to have a portion of our thyroglossal duct that is going to fail to involute. So if it fails to involute and fails to obliterate, this can sometimes lead to an anterior midline neck mass. So you can see over here, this patient has an anterior midline neck mass, kind of like a more pronounced Adam's apple, but very definitely a mass, and it is going to move with swallowing. The fact that this mass moves with swallowing is going to be really key for you to differentiate it from some other neck masses, such as brachial cleft cysts or cystic hygromas that do not move with swallowing. So your brachial cleft cyst, of course, is going to be a remnant of the brachial cleft, and then your cystic hygroma is going to be from lymphatic tissue, so they all have different embryological origins, which could definitely come up in a board style question. But additionally, these two are not going to move with swallowing. And then if you want to differentiate them further, if you have a mass that doesn't move with swallowing, another good clue about the origins of these two masses is that brachial cleft cysts are often lateral, whereas cystic hygromas and your thyroglossal duct cysts are often midline. So if you have a lateral mass that does not move with swallowing, most likely a brachial cleft cyst. If you have a midline mass that does move with swallowing, that's most likely a thyroglossal duct cyst. Then management of these thyroglossal duct cysts is going to be surgical removal, and that is usually curative. All right, so I know that was a lot of information. Let's quickly recap. Some important things to remember about the embryology of our thyroid is that we're going to start out with this endoderm between the first and second pharyngeal pouches. We are going to have an outpouching at the foramen cecum. This is going to lead to our thyroglossal duct, which is going to dangle our thyroid off the end of it during its descent. The thyroglossal duct needs to involute around week 8 to 10, so we don't get a thyroglossal duct cyst. And then also during this time, we are going to have our superior parathyroid glands originating from the fourth pharyngeal pouch and our inferior parathyroid glands originating from the third pharyngeal pouch. I like to remember that the bigger number goes on top, and that gives rise to your superior parathyroid glands. And then two problems that can occur with this process are either failure of our thyroid to descend all the way down our thyroglossal duct. That could lead to ectopic thyroid tissue, usually at the base of the tongue, but it can be anywhere along the thyroglossal duct pathway. This can lead to a cough, difficulty swallowing, or snore. And then another problem that we can have is our thyroid thyroglossal duct cyst. So this will occur if our thyroglossal duct fails to involute. And if we do have a thyroglossal duct cyst, it's important to remember that this will be an anterior midline neck mass that does move with swallowing, and that will differentiate it from a brachial cleft cyst or a cystic hygroma. But how would they ask you about this in a board style question? Well, something they might ask you is a patient presents to clinic with a midline neck mass. The mass is firm, non-tender, and does move with swallowing. This patient's pathology is the result of the failure of which structure to form properly. So this question is asking us about a midline neck mass that does move with swallowing. That seems pretty classic for a thyroglossal duct cyst. And then it asks us that the thyroglossal duct cyst is the result of the failure of which structure to form properly, because it's actually the failure of the thyroglossal duct to obliterate, but I would still choose thyroglossal duct as your answer on step 1. Now I hope this video was helpful, and I'll see you next time.